Good evening, all. I welcome you to the 15th edition of our TMC Metallogs. Today, we have a very distinguished guest, and now I invite Dr. Sujata Madam to introduce our guest to our August audience.
Good evening, everybody. I think it's my proud privilege to introduce Dr. Ashok Vellodi to the audience. He's a medical graduate from the University of Pune and did his MD Pediatrics from AIMS, New Delhi. And then he went to UK to acquire his further degrees in pediatrics. And he was the consultant pediatrician metabolic unit at Great Ormond Street Hospital for Sick Children, NHS UK. And he has a very great interest in lysosomal storage disorders. And he has over 100 landmark publications in reputed journals. And the connection between me and Dr. Ashok Vellodi is we have done several clinics together in for the children with lysosomal disorders in India. And he was also a key opinion leader in our Indian Medical Advisory Board, which selected patients who were eligible for enzyme replacement therapy. And he was a great teacher for me. And he has taught about management and diagnosis of lysosomal storage disorders, not only for me, but all the metabolic physicians in the country. And the interest and passion and commitment. So many things to emulate and learn from him. And he also recently introduced me to palliative care and proudly saying that we are running a very, very successful palliative care unit for children with rare disorders at VHS Adayar. And recently, he introduced me into the field of epigenetics as well. And then we had a great conference in New Delhi, only talking about epigenetics and its clinical applications and research. And now I invite Dr. Ashok Vellodi to give his talk on DoHAD, an Indian perspective. Over to you, sir.
Sir, I'll stop sharing. You can share your slides now, sir.
Okay. Thank you, Dr. Venkatesh. Thank you, Sujata, for those kind words. As Sujata has mentioned, my background is in lysosomal storage disorders and my sort of lifelong interest. But first and foremost, I'm a pediatrician. And recently, I have become interested in various aspects of the Indian healthcare system. The most recent has been this topic, developmental origins of health and disease, which I think every pediatrician should know about. So I would like to share my thoughts and excitement with you. So I'm going to turn off my video now because it's 1 minute. Yeah. Okay. So the development origins of health and disease, also known as DoHAD, I'm going to present it from an Indian perspective because there are some unique features in India that we need to know about. And so why are we talking about this? It's because of the rising prevalence of NCDs, non-communicable diseases. There are 4 broad groups: cardiovascular, diabetes, respiratory, and cancer. And there are certain unique features of NCDs in India. Type 2 diabetes and hypertension are seen at a normal BMI. There's a unique profile that Indians have, which is more atherogenic. There's a very high proportion of central obesity. Coronary artery disease occurs at a younger age. There are distinct cancer profiles in India, and there are distinct pollution patterns. I don't have time to discuss all of this, so I really just want to discuss some basic concepts. Why? So it's obvious in 2019, 2/3 of all deaths in India were due to NCDs, and there's a 22% probability of dying prematurely from an NCD in India. And these are just some charts to show you that the prevalence has been rising over the years of the main NCDs: obesity, hypertension, and type 2 diabetes mellitus. And similar trends are seen in children. So what are the questions? Why has this happened? Why now? And what can we do about it? So this brings us to DoHAD. What is DoHAD? It is the link between early life environment and lifelong health and disease risk. So none of this would be possible without David Barker's findings. David Barker was a physician and epidemiologist in Southampton in the UK, and he was doing some work in various parts of England and Wales. Sorry, I don't know where. I don't know why that's. So he was studying diabetes, but he found a strong link between communities where there was a low birth weight. There was a very high risk from cardiovascular disease. So these were the poorest communities, and it's completely the opposite of what you would expect. Now, before I move on to actual DoHAD, there are some basic science concepts that you need to know about. One is the epigenome. What is the epigenome? It's a sort of matrix that surrounds the genome. Our DNA cannot change, but the way in which it's expressed can change. So it's like electricity going to a light bulb. You can't change the amount of electricity, but you can change the brightness of the bulb. And the dimmer switch is the epigenome. It surrounds the genome and decides or controls how it is expressed. And this is another name that you should all know, Conrad Waddington. In 1942, well before the discovery of the double helix, described the epigenome and this epigenetic landscape. So at the top, the little ball is your primordial germ cell. And as you can see, it rolls down this slope, but it can take any one of a number of routes. Which is independent of its DNA. Its DNA is already formed. So this was a very famous drawing. The other concept that you should know about is insulin resistance. You really don't need to look at the slide in detail, just to emphasize that insulin resistance is not just about diabetes, but insulin resistance results in a large variety of medical problems and a lot of NCDs. And the third is the folate trap. What is the folate trap? Very important in India. So B12 deficiency is extremely common in India, and it has two main problems. I don't know if you can see so one is megaloblastic anemia and the other is neurological. There are others, but let's just focus on these two. It is estimated that in some parts of India, the prevalence is as high as 60%. Now, what is the folate trap? We give folate supplementation, especially in selected cohorts such as pregnant women, but this must be accompanied by B12 supplementation. And failure to do this, not only are the neurological it corrects the megaloblastic anemia, but it does not correct the neurological complications and may make them worse. So let's look at the pathway. Folate enters the body, usually in the diet. It's converted to tetrahydrofolate, methylene tetrahydrofolate, and this compound, methyl tetrahydrofolate, which derives its methyl group from here. Okay. Now, methyl tetrahydrofolate gets converted to tetrahydrofolate. Why? So it loses the methyl group and donates it to this cycle, which is the methionine cycle. Why does this cycle require methyl groups because homocysteine is converted to methionine, which is converted to S-adenosyl methionine, SAM, which is the universal methyl donor in the body. Okay. Now, methyl tetrahydrofolate cannot donate methyl groups because in this compound, the methyl groups are really caught very tightly. B12 drags them out of this compound and donates them, brings them to this cycle. And only if B12 is present will this cycle happen. So you've got two cycles going in parallel, the folate cycle and the methionine cycle. Now, just imagine if B12 was deficient. So immediately you would get a rise in methyl tetrahydrofolate. That itself is toxic, okay? This, remember, does not donate its methyl group. So you've got this large pool, it's like a sump of a folate compound, and the methyl is trapped in it. And as a result, this cycle does not receive any methyl, which means that homocysteine does not get converted to methionine and SAM does not form. And methylation throughout the body stops. And if you have complete deficiency, methylation stops completely, and that is lethal. Okay? So, in the absence of B12, two things happen. This compound goes up and SAM goes down. Very important to remember this. That's why with folate you have to give B12. Now, in the past, people were giving folate supplements in pregnancy without giving B12. And then they found that the homocysteine levels were rising, which they would. So those of you who are familiar with treating pregnant women with folate supplements in the absence of B12, they found that the homocysteine levels in the blood rose, and that's not surprising. Okay, so let's move on anyway. So the question is, how is the fetus prepared for the environment? And what happens when this preparation is insufficient? So in the fetus, you have maternal and paternal imprinted genes, okay? And there's always they don't always agree with each other, basically. The conflict has to be resolved at the placental level before a decision is made as to what traits to pass on to the fetus. Now, in a normal situation, everything's fine. The maternal and paternal alleles do what they're supposed to do, and you get a nicely formed child. What can happen? Well, three things. One, there's a mismatch between what the fetus was programmed for and what it encounters when it comes out. There can be direct damage to the fetus in utero, and there can be inherited problems. So we'll talk a little about this. I just want to briefly mention pollution and DoHAD. I'm not going to talk about this in detail, but pollution is not just about lung disease. The placenta is exquisitely sensitive to pollution and results in all sorts of problems. And you can immediately see this, and you can really, you'll need to go away and read it up. I mean, there's so much going on with pollution, so much more than just the lungs. Okay, so here you have an undernourished mother, and she sees, or her system sees outside, nutritional problems, pollution problems, stress problems. That is the exposome, the environment. That is what the fetus is going to be exposed to. She immediately restricts fetal growth. Why? Because this is a protective mechanism. Poor maternal nutrition results in fetal growth restriction. Why? Because the mother wants to conserve energy and divert glucose to the brain. Man is the only species in which this happens. This maximizes survival. It maximizes survival in pregnancy. And this is known as thrift. It's called nutritional thrift. So you get a thin child with what's called the thrifty phenotype. But, okay, so you've got the nutrient poor maternal environment, and you can either have a thin child or and if that continues in a nutrient poor environment, there's a survival advantage because that fetus is born with a survival advantage. But the minute the child and young adult is exposed to a nutrient rich environment, there's a metabolic disease sets in. So how does this happen? Okay, in normal neonates and infants, fat is preferentially starts accumulating subcutaneously. This is a fact, okay? But adipogenesis commences only in late gestation. Before late gestation, there's no significant adipogenesis. So just remember those two statements. I'll come to both of them later. Now, when there's a mismatch between the environmental, the environment that is programmed for and the actual environment, you get maladaptation. So, as I said, the fetus is born with a low, lean body mass, thrifty phenotype. But in Indians, there's this unique phenotype called the thin fat phenotype. What is the thin fat phenotype? It was first described by Chittaranjan Yagnik and his colleagues at the Pune Maternal Nutrition Study. It's a very famous study. It's one of the finest in the world, actually. He couldn't get this paper published for several years. But what he did was he took a group of neonates who were born in Maharashtra and compared them with a matched group, well, matched as far as could be done, born in Southampton in the United Kingdom. And he measured the mid-arm circumference and the subscapular fold thickness. And you can see on the left, the mid-arm circumference was lower than the than the Southampton cohort in all the Indian children. The subscapular fold thickness was also lower, but not as low. That's the first thing. The second thing was that with age, you can see this is birth. With age, this discrepancy gradually reduced, but not completely. This is Chittaranjan Yagnik's famous YY paradox paper, okay? That's him on the right, sitting next to a European colleague. They have identical BMIs, but you can see that Yagnik has a body fat of 21.2%, whereas his colleague body fat is only 9.1% with the same BMI. And that is what he was trying to get at. So let's see what happens. Now, this is not Yagnik, okay, but on MRI. So here you have two adults. They have identical BMIs, but this adult has far more, on the left, has far more internal fat than this adult does. Immediately, that confers a higher disease risk. Now, as I said, adipogenesis commences in late gestation. Now, if exposure to the adverse environment is in early gestation alone, you get the thrifty phenotype only. But if it's sustained throughout gestation, you get the thin fat phenotype. Because only in late gestation is adipogenesis affected. So you get a child who appears slender, but has relatively high body fat percentage. This is easily missed. There's a very high prevalence in South Asians, even South Asians who are born abroad. This is very important. It doesn't have to be born in India. And there's a very high metabolic risk from the beginning. So As soon as the child comes out, he has a normal BMI, but immediately, the Yagnik's study found this, that they have insulin resistance at every age, starting from birth. They have higher systolic blood pressures and a higher body fat. Plus, they found, and this was the first group in the world to describe this, that the insulin resistance at every age was associated with low B12 and a high folate. What is that? That's the folate trap, okay, which results in insulin resistance. This was quite unique to Indians. So this is just to show you how it's very rough diagram. The fat mass increased, the lean mass came down, insulin resistance went up, blood pressure went up slightly from birth all the way to childhood to adulthood. So, to repeat, there's a metabolic risk in the Indian thin fat neonate, even in normal circumstances, as soon as they're born. That's very important. What is the risk? Just to recap, insulin resistance, dyslipidemia, ectopic fat deposition, and low muscle mass. Think of it as a 3-lane motorway. So normally you have traffic flowing quite nicely. The thin fat child is born with the same amount of traffic, but the third lane didn't get built, but nobody stopped the traffic. So there's immediate congestion at birth. And on top of that, if you get anything, an environmental stress of any sort, you can see the traffic building up rapidly, resulting in maladaptation. There is a biochemical basis for this. It basically revolves around an epigenetic change in the adipoc gene, which controls obesity. There's a low adiponectin expression, which is not good because that results in increased insulin resistance, inflammation, and oxidative stress, all of which are highly damaging. So, the second statement I made was that in normal neonates and infants, fat preferentially accumulates subcutaneously. But in the Indian thin fat neonate, subcutaneous adipose tissue is relatively preserved compared to body size, as you saw, but is a smaller absolute amount. And it has been epigenetically modified. So these adipocytes are sick from birth. So they cannot expand. Normally what happens is that as the neonate grows, the subcutaneous fat increases and you get a nice rounded baby. That doesn't happen in this thin fat neonate because the subcutaneous fat simply cannot expand. Therefore, there's an overflow into visceral fat, and this is known as the fat overflow hypothesis. And this is visceral fat, okay? It accumulates around the intestines and, importantly, the liver, okay? Visceral fat is very harmful, okay? It results immediately in increased insulin resistance, which is mediated by the liver. I don't have time to go through the pathway, resulting in a high risk of type 2 diabetes, hypertension, cancer, cognitive decline, very wide ramifications. Now, something very important to state, visceral fat may progress to truncal obesity, but it may not, okay? So you can have visceral fat without truncal obesity, and similarly, you can have truncal obesity without visceral fat. Not everyone with truncal obesity has visceral fat. So you will see in India, in some states more than others, truncal obesity is very common, but not all of these individuals has visceral fat. Now, individuals with truncal obesity who have visceral fat are at far higher risk. It's not to say that truncal obesity without visceral fat is completely benign, no. But with visceral fat, that's bad news. So the next stage of maladaptation is the metabolically obese, normal weight individual, MONW. This person has a normal BMI, but as a result of progression of the thin fat phenotype, has insulin resistance, dyslipidemia, hypertension, and a pro-inflammatory profile. So you got the thin fat individual. If he's faced with an obesogenic environment, classical obesity develops. That's very obvious and it can be seen, it's visible. But if the energy excess is only modest, you get MONW, and that's actually much more dangerous because it's not that obvious. But these individuals are actually more at risk. So, fetal growth restriction, environmental triggers, and you get these three outcomes. I put classical obesity in a small square because actually that's less important. The two important outcomes, the most lethal outcomes, are MONW and the metabolic syndrome. All of you are familiar with metabolic syndrome. Now, these abnormalities are seen in Indian school children. So if you look, this was a study done by Kalaimani Mani and her colleagues in Delhi. They looked at public and private schools, and they found that MONW was seen in both groups of children, but were more common in children attending public schools. Now, almost by inference, these children would come from a lower socioeconomic status. Now, for this study, for the first time in India, it's shown that children coming from a low socioeconomic status actually are at higher risk of metabolic disease. And it's not to say that the high SES children were completely exempt, but it was weighted towards the lower SES children. Now, this is very likely to be the case. So if you did a study of the schools in Tanjore, I'm sure you would find the same pattern. Saying which, Delhi is in North India, Tanjore is in South India. There may be differences, but there are likely to be similarities. Now, the thin fat phenotype, as I said, is very common in India. Why? Well, there are a number of triggering factors that are particularly common in India. So from ancient times, so clockwise from top left, feast-famine cycles, maternal insulin resistance is very common in India. Pollution is very common. It's one of the most polluted countries in the world. I put these two in yellow because I think, from my reading, these are the two most important and most frequently overlooked. If the mother has had a thin fat phenotype as an adolescent, she is much more likely to give give birth to a child with thin fat phenotype. And this explains why a mother living in the UK can give birth to a child with a thin fat phenotype if she had a thin fat phenotype as an adolescent. Okay? And the last one is maternal micronutrient imbalance. Again, frequently overlooked, micronutrient deficiency or the hidden hunger is extremely common in India. Not just B12 and folate, but zinc, selenium, vitamin D, iron, vitamin A, and so on. I think you all know what micronutrients are. It's a completely different subject, but I'll just mention it. So, very important to pay attention to it during pregnancy. Now, this study was done in 2019. This group took some ancient South Asian skeletons, okay? On the x-axis, there's the bone length. On the y-axis, there's the bone breadth. The colored dots are South Asian dots. The gray dots are global, the rest of the world, okay? And as you can see, these are skeletons going back to the Mesolithic period, so at least 10,000 years, at least to the beginning of the Holocene. So and not only that, they found that by examining these bones, the muscle attachment points were very small. Therefore, we can safely surmise that Indians have always had small bones and muscles. Why? Well, we don't know, but it may have resulted from environmental fluctuations and feast-famine cycles. India has had feast-famine cycles going back hundreds of years, if not longer. There have been environmental fluctuations. We're not just talking about climate change. I don't know if you've heard of the ENSO, which is the El Nino Southern Oscillation. Okay, so this resulted in huge climate fluctuations. So environmental fluctuations forced ancient Indians to adapt, but they didn't get NCDs. Why not? Because initially the environmental changes were slow. So therefore, the adaptive processes had time to evolve, okay? But we've taken care of all that. The changes in the Anthropocene have been so rapid that they've completely destroyed the face of the planet and changed the environment drastically. And it has been very difficult to keep up. Therefore, there has been rapid maladaptation. So things like obesogenic environment, pollution, these are all our creation. And this has resulted in NCD. So I think we can safely say that ancient Indians probably had a very low prevalence of NCDs. Indians are vulnerable to the exposome because the priority in their fetal program was survival. But the Anthropocene has resulted in maladaptation. These fetuses were not programmed for this particular environment. So, just to mention that hypertension has a very similar basis. This is called, so you had nutritional thrift. Well, this is renovascular thrift, okay? And this is known as Brenner's hypothesis. So low birth weight infants born to low birth weight mothers, or undernourished mothers, have fewer nephrons, salt and water conservation, and increased vascular tone. But the minute they go into a sort of adverse environment with high salt intake, stress, and pollution, it results in hypertension. This is one of the important causes of hypertension in India. We can actually split it into developmental origins of health and developmental origins of disease, actually. And one is adaptation and one is maladaptation. Now, this slide I've put just to sort of make the point. I won't go into detail, but basically it's my theory that gestational diabetes is a modern disease. Why? Because in the ancient environment, so the fetus needs glucose, okay? It cannot grow without it. And but it doesn't produce its own. The glucose has to come from the mother. Therefore, the placenta freely transports glucose and it favors glucose entry from mother to the fetus. This is adaptation. Fine. But in the modern environment, there was energy abundance, a high glycemic diet, reduced physical activity, resulting in chronic hyperglycemia during pregnancy. And you know what the effect of that is. The fetus doesn't produce glucose, but it does produce insulin. You get fetal overgrowth, etc., etc. So I don't think that gestational diabetes existed in ancient Indians, but that's just my personal theory. I may be wrong. Okay, so we talked about the exposome, and we talked about the ways in which the exposome causes DoHAD. Mismatch, direct damage through the, I talked to you about pollution, and then there's inheritance. So this is a very famous, no, I shouldn't say famous, I'm sorry, I apologize, that's the wrong word. The Dutch winter hunger of 1944-1945, during the Second World War, the Germans cut off supplies food supplies to the northern Netherlands. Why? Because they sympathized with the Allies. This immediately resulted in acute famine, thousands of deaths. It's a very, but the thing about this study is that this cohort has been followed up for decades. So we have some data on this. So there was exposure in utero resulting in a higher risk of type 2 diabetes and CVD in the F1 generation. But in the Dutch winter hunger, there was no evidence that this was transmitted, or at least there's no published evidence that it was transmitted to F2. But I think there's a high risk of transmission in South Asians. This has not been proven, but it's just my theory. Now, why do I say this? Why? Because the Indian thin fat child is already stressed and vulnerable. Okay, so going back to the previous slide, you've got a thin fat child who looks happy, but he's actually stressed. You get environmental triggers, you get all these problems. Dutch children were not previously stressed and vulnerable. Therefore, the Dutch winter hunger was an example of acute epigenetic scarring. Indian famines like the Bengal famine were an example of acute on chronic. And therefore, it's highly likely that these effects are more likely to be transmitted through generations. Unfortunately, we don't have good long-term data from the Bengal and Deccan famines. But if anyone's aware of it, please do speak up after this. Now, what are the critical windows for intervention? I think everyone knows this. First 1,000 days, everybody knows about. What people don't always appreciate is adolescent girls is absolutely critical window of intervention. So the first 1,000 days, we know lifestyle of the mother is aimed largely at the mother. Treat GDM, micronutrient supplementation, omega-3 LC-PUFAs, and the mental health, again, very important. I think everyone knows this. Now, adolescent girls, slightly different approaches in rural India and urban India because the problems of adolescent girls slightly different. In rural India, I think the thrust should be on anemia and micronutrients. Delay early marriage and pregnancy, if at all possible, and reduce biomass fuel exposure. I think people know what this is. We're talking about clean cooking fuel, okay? Now, all these things are easier said than done, but I think that should be the thrust in villages. In the urban areas, metabolic health, because the obesogenic, the thin fat phenotype decompensating is much more likely. Mental health in urban areas is a major problem, and reduce ultra processed food consumption. Now, these are not neat boxes, okay? All these apply to both rural and urban. I'm just trying to prioritize because if we go to the powers that be, tell them how to spend their money, we have to have some idea of how they should spend it. Now, I just wanted to make a statement. I don't have time to talk about this in detail, but it's really important, and people don't appreciate this, that brisk exercise reduces insulin resistance even without any weight loss. This starts within hours. Within hours, actually, through the GLUT4 transport receptors, which actually transport glucose into muscle. Anyway, there are a number of mechanisms, but it's very important to tell anybody who wants to listen, basically, that because a lot of people say, "Oh, I haven't lost weight," that actually doesn't matter quite so much. What does matter is getting the muscles exercised. I'll just briefly mention PCOS, very common in Indian women, but importantly, again, it's seen in women with a normal BMI. And this is called lean PCOS. It's a bit like the thin fat phenotype. And in fact, they have a very similar metabolic basis. So thin fat phenotype, insulin resistance, hyperinsulinemia, ovarian effects of hyperinsulinemia, PCOS. So I'm coming to the end here. So you can say you can have an adaptive outcome which very quickly goes to a maladaptive outcome. Going the other way is not quite as easy. And we also need to appreciate that developmental plasticity and therefore the effects of treatment are far greater in early life and preconceptually. Never forget the adolescent girl. I keep repeating that. So mother and infant really is where the focus is, but some effect on childhood and adolescence and adulthood. So we've let the genie out of the bottle. Can we put it back in? I don't know. That's it. Thank you.
Thank you, sir. That is a wonderful lecture. I think it summarized in a very easy terms, trying to understand the overall concept of Thrifty gene hypothesis, the Barker and the Brenner's hypothesis. And now I open the floor for questions or comments from the audience. First, Dr. Sujata, madam, would you like to make your observations?
Yeah, it was a wonderful lecture, Dr. Ashok Vellodi, and then really opening up our thoughts on the adolescent health. I think more focus has to be given on the adolescent girls, and especially the nutritional imbalance which the current generation is facing. And I think more focus on prevention rather than curative care, I think will be the long-term goal of health maintenance in India. Thank you for opening up this fantastic idea, sir. And I request all our alumni friends to ask their doubts or questions or place their comments.
So, good evening, sir. I am Dr. Ravi from Trichy. Am I audible?
Yes, sir. Yes, sir. Go ahead.
Yeah. So actually, is there any study done on how the stem cells are affected in the infant and in the in the postnatal stages, when actually the formation of the fat, whether it is the brown fat or the white fat, how much of that gets converted to brown fat, which is good, and the white fat that is responsible for the insulin resistance?
Oh, yes, there's lots of work that's been done on that. And yes, I mean, well, we can, there's that opens up a whole new field of discussion. But in the short answer to your question is yes, there has been work done. And I think uh, the work, the epigenetics has really opened up our understanding of what happens to these adipocytes and why brown fat does not form and why you know, sort of toxic fat accumulates. Yeah, so but the answer to your question is yes, there is work.
Thank you. Thank you.
Sir, you talked about early interventions antenatally or intranatally for preventing or the risks of developing later non-communicable diseases. Can you kindly elaborate what kind of interventions would be beneficial, sir?
Sorry, what kind of?
Interventions would be beneficial.
Well, you have to start you have to start from adolescent girls because you have to prevent the thin fat phenotype in the first place. You have to obviously work on maternal health during pregnancy. You have to raise awareness. You have to avoid the folate trap. You have to really focus on micronutrients. The micronutrients are really neglected. I mean, and I wouldn't say totally neglected. I mean, people are beginning to understand it. But for example, there was a very well-known study done in Wayanad in Kerala some years ago, where they looked at a tribal group of adolescent girls and showed that the prevalence of anemia had not changed at all despite their overall nutrition improving. So a lot of people think that just by giving more protein, carbohydrate, and fat, you solve the problem. That's not true. You're left with this micronutrient deficiency. So you've got to pay attention to that. You've got to screen. Uh, you've got to set up screening programs, and that's the tricky bit, because raising awareness or in um, the most vulnerable people are going to be the least literate. So how do you raise awareness? Well, I showed you that diagram of the motorway. That's quite a nice conceptual diagram, and I think one has to convey it through or pictures and figures. Yes, we need to improve literacy, but that's going to take a long time. Some states are doing better than others, particularly when it comes to adolescent health. But across India, sustainable development goals are not being met. There's huge regional inequality, and I think each state needs to develop its own programs because, um, yeah, I think but for example, if you go to Karnataka, Bangalore has a profile that is quite representative of Karnataka. But that's not true of all state capitals. Okay. So you really have to, it's impossible because healthcare is devolved. We've got a federal healthcare system. We cannot solve it from the center. We can tell the center what is required at state level, but we need to look at the problems in our own states, look at the prevalence. For example, diabetes is commoner in certain areas. In the Northeast, they have a very different NCD profile, for example, so they may have a different approach. So I think your prevention really depends on who the target population is.
Sir, Neelakandan, sir, can you post a question? Would you like to voice it, sir? Okay, let me read that.
Dr.
What are the...
Okay, sorry.
Yes, sir, please go ahead, sir. Dr. Bose, please go ahead, sir.
Sir, this is Dr. Bose, right? Sir, my question is, once the genie is out of the bottle, right?
Yes.
Now, you created a thin phenotype or a fat phenotype or whatever you were describing about, and it was very nice that the insight what you are creating is very appreciated, and I think it would really go a long way in helping us control even malignancies to a large extent. You were talking about the insulin resistance and the pro-inflammatory responses, which are very true in inducing any malignancy. Now, what do we advise these genies who are out of the box or the bottle?
Okay, so my opinion is that we'll never be able to get the genie back into the bottle because the pace of change is so rapid that I don't know, we can try and mitigate problems, but remember that the thin fat phenotype is a very ancient origin. We're going back thousands of years. Things are not going to happen in a hurry, okay? And I think the rule of thumb is that you need at least 3 generations to start seeing any effect. So I think we're not going to see any dramatic changes certainly not in my lifetime. We should be patient because this is definitely going to take time. If at all we see, we will never see reversal, but even to see improvement, it could take at least another 3 to 4 generations.
Thank you, sir. Thank you very much for your insight.
Dr. Neelakandan, sir, you're there?
Sir, I have a question.
Please go ahead, ma'am.
I'm Dr. Uma Kalyani, sir. It's a very good talk. I am basically a geriatrician. We have some concept called sarcopenic obesity in the geriatrics, where patients are obese, people are obese, but still they are frail or sarcopenic. Like that, when I see a parallel here, metabolically obese but normal weight. How can we identify those people? It's only by MRI
Yeah,
or
well, that's a brilliant question. So you're absolutely right. This is sarcopenic obesity. Thin muscle at any age predisposes to insulin resistance because muscle is required to take up glucose. And the minute you don't have muscle, you've got a problem. And that is why within, as I said to you, within hours of exercise, you start seeing effects. I mean, I've got a separate slide which I haven't shown to show you there are four different mechanisms by which muscle exercise starts working. But even a brisk walk starts activating the GLUT4 receptors. Even in elderly, you will find that, see, there's a difference between obesity and insulin. So insulin resistance is the key. If you can start reducing insulin resistance, that would be great. Now, to look at visceral obesity, there are simple, I think Sujata will know more. We talked about this at the meeting last week, like impedance machines and so on. You don't need an MRI every time. But there are also tests like the HOMA-IR. Are you familiar with this? HOMA-IR. That is a test that's done very easily. You can go to a lab and get it done. It measures your insulin resistance. And you can start working on that straight away and reassure your patient or whoever it is that they need not necessarily notice a reduction in obesity. But sorry, even before a noticeable reduction in obesity, they will start getting a noticeable reduction in insulin resistance with a parallel decrease in metabolic risk.
So there's a
Does that
question in the
make
chat
sense?
box.
Yeah, I got the answer. Thank you.
Yes, sir. Sir, regarding the modern day interventions for the metabolic syndrome, dietary interventions, amongst the modifiable risk factors, one is the dietary interventions. And increasingly, there are the low carb diet is one that is being advocated by many agencies, including ADA, where energy excess is counted first in order to improve insulin resistance. So, would the dietary intervention?
So,
Yes, sir.
from what I've read, that is not the answer. I think balanced diet is far more important than reducing your carbohydrate. And I think this is I'm not a nutrition expert, so I speak advisedly. But simply reducing your carbohydrate intake is not going to do the trick on on its own, is my understanding. It needs to be a balanced diet. You need to pay attention to other things like exercise, stress. The HPA axis is activated. We didn't talk about that, but glucocorticoids are a very potent factor. So the HPA axis really triggers many NCDs. That's why you need to. It's very true that you should avoid stress during pregnancy, and this is why it's not just some old wives' tale. And people who are not aware of this, please go and read up about this. The HPA axis, the hypothalamic pituitary axis, is absolutely fundamental to this condition.
So, what do you think of the GLP-1 agonists, which are being increasingly promoted for weight loss? So, do you think that would kind of mitigate the risks in Indians?
Sorry, I don't know. I will be honest, I don't know the answer to that.
Are there any further questions?
Sorry, one more thing I wanted to say. Just does everyone understand the folate trap? This is very, very important. I mentioned to you that there is a deficiency of methyl groups and methionine drops. What you should never do is give methionine during pregnancy. That is basically lethal. Okay, it not only potentiates the effect, but methionine in itself is teratogenic. So, in all circumstances, avoid that. The second thing I wanted to say is we didn't talk about vitamin D, but vitamin D is not just about bones. Vitamin D has a vast um, array of actions. I mean, it's on all sorts of things like DoHAD, cancer, respiratory disease with vitamin D deficiency. And so, yes, there are lots of reasons for supplementation of vitamin D.
Yeah, thank you very much, sir. I think it's a beginning for all of us to think on these lines of care of the adolescent girls, especially the micronutrient environment of these girls, and also care, more focus on the mother's health. And as Dr. Uma Kalyani had portrayed the geriatric health. So everything, I think we need to keep this in mind. And though we may not be able to reverse things, at least we can keep things under check. And as you said, the exercise, I think exercise has to be promoted more than diet. I think that will help our Indian people. That's what I get the message from your talk. And thank you very much, sir, for your time and giving us insight into this wonderful topic. Thank you very much, sir.
I see a question in the chat box, sir, and probably Dr. Priya, you have a question. Can you just unmute yourself and ask? She wants to know what about the proportion of macronutrients during pregnancy.
Hello, sir.
Yes, Dr. Priya, go ahead.
Yes, sir. Good evening, sir. I missed the initial part of lecture. I'm sorry I could not be there. I don't know if it was told already or not, but I want to know what is the proportion of macronutrients that can be suggested during pregnancy and from adolescence. Is there any difference or it is the same? If it is the same, what is it? And one more question is the dosage of vitamin D3 and calcium supplements to be given during pregnancy, because it varies widely from private and government setups. And regarding methylfolate supplement, which is better, like folic acid they give in government, but few people they say methylfolate is the best, don't go for folic acid. I want to know better in that, sir. I'm sorry if this is so simple question that I don't know.
So there are several questions there. There are ICMR guidelines for diet supplementation during pregnancy. One thing I should tell you, and this actually came up last week when I was talking, should folate and B12 be prescribed to everybody for life? The answer is that is not being recommended currently by the government of India, only for certain target populations, such as pregnant mothers, adolescents, etc., etc. I don't know the doses. Methyl tetrahydrofolate, the active form is said to be preferable, but I'm not an expert on that. And I think you may have missed the first bit where I showed the diagram of the folate trap that illustrates why, when and where to put folate. I think it illustrates that.
If there are no further questions, can we wind up the
Regarding
session?
the proportion of macronutrients, sir, for during pregnancy.
I don't know the answer to that. What I do know is that there are ICMR recommendations which are widely available.
Okay, sir. Thank you. Thank you, sir.
Sir, Dr. Sujata ma'am, your closing comments?
Yes, sir. That's what I told. So thank you very much, sir, for your time and for giving us insight into this very, very important topic. And I think a more focus should be given on adolescent health and pregnant women for getting a healthy generation, future generation. And as Sir told, we should keep in mind that it is going to take generations for us to see a change. So, but then I think small steps should be taken from now on to at least ensure that future Indian generations are healthier than what they are now. So thank you very much, sir. Thank you very much. Yeah.
Sir, your closing comments, sir.
Well, I just hope that, because I feel very enthused by this concept. I started reading up about it when I saw the rising prevalence of NCDs in India, and I started asking myself the question, why is this happening? And I've been fortunate in having access to people like Gira Chandak, who is one of the pioneers, along with Chittaranjan Yagnik, and he's really educated me and guided me along this path.
Yes, sir. Thank you so much, sir. Thanks for making time for our forum. And it's been an Indian honor and privilege to listen to a very important topic. I think when we discussed it over the phone, I went back immediately and looked at DoHAD and kind of brushed up my knowledge, and I found a considerable amount of scope for interventions as far as nephrology is concerned, because the population is getting older and we have hyperinsulinemia, insulin resistance, OMA-IR, all those things have become extremely important for us now. So I think every specialty has a take-home message from this talk. And there's a very powerful teleological argument. And you find that what happens in the Anthropocene era, the maladaptation during that period, and the kind of inheritance that happens during the feast-famine cycles, these are very important points worth emphasizing. And I'm happy to say that this record will be available soon, and I'll be sharing the link to everybody. So kindly share it widely, and please go through this. And we need to disseminate this piece of knowledge to every clinician in India. Thank you so much, sir. With that, I think we'll wind up the talk for the day. Thank you so much once again. Thank you all.
Thank you, sir. Good night.
Thank you. Thank you very much.